Hello, everybody. Thank you for coming. I'm Joe Cosentino, Chair of the Activities Committee, and this, as you know, is Community Connections. And the good thing is, if I should drop right now and faint, we have a doctor here, and 2 nurses, and Philip, who's in charge.
I don't know what I'll do.
Yeah, I don't need you.
Thoughts and prayers.
Jill Ortner, who is the chair of the Health Center Committee, was going to conduct the interview, but she had an emergency. So we have Margaret Nyhouse, who is the old, I shouldn't say old, the past chair, former is better than old, the past chair of the Health Center Committee, and she's going to conduct the interview. So I'm going to pass the microphone to Dr. Antoine and turn it over to Margaret.
I do want to welcome you first to the Community Connections. And first I want to say that those of you who attended the Residents' Council meeting this morning have heard my voice enough today. Anyway, so I am a member of the committee and have been since 4.5 years. I've been here 5, so I've enjoyed my connection with them. So first we're going to start with the doctor, and then we're going to go along, and I'm going to ask each of you to introduce yourself, with your name of course, and then a little bit about your education if you would, and what you did immediately before coming to Woodland Pond, and probably most important to everyone here, what are your duties? In other words, what does a resident come to you for, asking for your help? So, doctor.
All right. I want to start by saying this is amazing. So thank you for inviting me, and thank you for having such a conference, because I've never seen such a thing before. So very much.
Dr. Holt, you've got these mics are very directional, right?
Better?
Yeah.
Sorry. So I want to start off by saying this is an amazing gathering, and I'm very honored to be here. So thank you very much for doing such a gathering, because I've never actually seen it done before. So I appreciate this. A little bit about me. I'm a first-generation doctor. I'm a immigrant to the United States, and I put myself through medical school. I went to the American University of Antigua. I was a single mother of 2, and I said I did not want to be a respiratory therapist the rest of my life. So I decided to go back to school. And I wanted to show my girls that if you put your mind to something, you can do it. So I decided to show them that this is what you do. So you'll never hear me say we can't do something, right? If you want to do something, we'll get it done. So I went to the American University of Antigua, and because it was a foreign medical school, you had to be able to provide your own funding and be able to pay for yourself. And as a single mother, that was not something easily done. So I decided to go ahead and get a master's degree from one of the American universities and use that money to fund my medical school. And a master's degree is only 2 years, so I had to get a second master's. So I did 3 degrees at the same time in order to pay it with my 2 kids. So I literally went to school from 7 in the morning to 11 o'clock at night. And my kids would sit outside the class, or they were part of the class entertainment to be able to get it done. So they've been in med school since they were knee-high, sitting either under the table, on top of the table, or they were the test subjects. And now they help me run my company as CDOC Medical Group. So they have seen it from me starting school all the way through to developing it. Being a medical doctor is not something just as a career. It truly, I love what I do. And I do not see it as a job. So half of the times, I just love to see that I can bridge the gap of communication between what's happening medically and what your understanding is of what it takes to get to the next course of life. And that can be medically induced, or it can just be understanding the mechanics of the body. So ask away. Sorry, that was an extended explanation.
Okay, let's go through and introduce everybody, and then we'll go back and let them ask away, as you put it. Gia?
Okay. I'm Gia Depuy. I'm the unit better? I'm Gia Depuy. I'm the unit manager on skilled nursing. I went to Seton Hall, I went to Seton Hall University straight after high school. I graduated in 2014 with my bachelor's of science in nursing. And I'm from Jersey, so I started my nursing career there, working in like a large practice as a float nurse. I did cardiology, oncology, GI, internal medicine before I became a head nurse for a cardiologist there. Then I moved up here to Highland, New York, and that's when I got into long-term care at that time. And I worked as a charge nurse with a neurodegenerative unit, and then I became a unit manager at a couple other long-term facilities, and did long-term care and subacute rehab, and then I found my way here to Woodland Pond. So I've been here as the unit manager for 2.5 years, and I think that just answers the first question, right?
If you would also tell them exactly who comes to you, what do they buy?
Oh, yeah, of course, the second question, yeah, sorry. So as the unit manager, I'm responsible for all of the nurses, the CNAs, unit assistants on the unit. So they all report to me. I do, for all of my, not all of my duties, but a lot of the time I am addressing like staff issues. I'm addressing any concerns, families, residents, that they have. They come to me, the staff reports to me, as well as the residents and their families. Am I going through like all my duties or?
Whatever you want.
Okay, all right. I had written down like my duties, but the question's a little different, and just what people, come to me with, and most, so that's not really answering that question, sorry. Yeah,
We'll have
I think
a chance
that's it.
again.
I think that's it for that, yeah. I'll come back to the other
Say more
stuff.
later.
I'll come back to the other stuff, sorry.
Hello, I'm Debbie, the Director of Nursing. I have my associate's degree. I start my bachelor's. I'm not done yet. I'm going to finish that hopefully by next year. I started about 15 years ago in nursing. I started a little later in life, and actually kind of like Dr. Antoine, I was a single mom of 3 girls and put myself through school. I started about 15 years ago. I started in a local hospital here. I was on the cardiac stroke floor, and then I had a good friend who was an administrator at the time at a local nursing home who offered me a position to do subacute unit manager, like Gia does now. I took it and I fell in love with geriatrics, and I never went back to the hospital. It's been my passion. I absolutely love it. I've done multiple things in long-term care, from staff education, employee health, infection control, and management and supervisor. And I worked my way up to director of nursing about 9 years ago. I started being a director of nursing at other facilities, so I've been doing this for quite some time. My role here is I oversee all of the nursing department, which is assisted living, garden view, and skilled. So I help with all that. I make sure we're ready for survey prep. I make sure we're in compliance with regulatory things. I do all the clinical operations. I pretty much do a little bit of everything in nursing. So I'd be the person you would come to for things. If the manager maybe can't figure something out or do that, then they would come to me for that. I am very close to my staff. I have an open door policy. I get messages all night, all day from my staff. Sometimes it's personal stuff. They just need someone to talk to. I'm very involved in nursing. And I think that's it for now.
Hello, my name is Philip Mehl. I'm the Director of Long-Term Care for the Health Center. My background started, I'm actually going to go to high school for a second. I went to high school at the Performing Arts High School in New York, and I bring that up because I thought I was going to have a career in theater and film, which I still love and I still have a passion for, and will perform now and then where I can, but the divide in the road came when it was time to go to college, and I had also I don't use the word often, but a calling to work in social work. And so I was searching for universities that would support a dual major in theater and social work, and it turns out there's no such animals. And so I had to make a choice, and it wasn't hard for me. I am a clinical social worker by trade. Although I'm the administrator here, I say I'm a social worker who happens to be an administrator. I love my field, and I appreciate the values that it has taught me to look at not only the context of how we are coping on the line of life as individuals, but also how we fit into a greater ecosystem and culture. That drives me, it fascinates me, and I love working in that. My first job out, I went to NYU for undergrad in clinical social work, and Columbia University for a graduate degree in clinical and systems-based social work. And my first job just happened to be in acute care. I worked emergency rooms in trauma cases in New York City. For Catholic Medical Center, I would be called around to the different hospitals within Catholic Medical Center care for child abuse cases, rape cases, trauma cases. I ended up at St. John's Queens Hospital, which is now closed, doing much of the same, but added some more stable discharge planning work to that. But as much as I loved the field of healthcare, it was frustrating to me not to see how the stories of patients continued. And that led my eye to long-term care, to form a relationship with the people I was working with, and to be able to continue on that journey with them was very important to me. And so that's when I moved into long-term care. In New York City, I started in various facilities as the director of social work, and then took my first administrator job at a facility in the Catskills, which is where I moved out of New York City. I also worked for Leading Age New York, which is a trade organization that supports not-for-profit healthcare facilities. I do consulting and policy work for them, as well as emergency planning. And concurrent to that, Woodland Pond was opening its doors. And after the initial few years of setup, Michelle and I had formed a relationship through our work back when Woodland Pond was part of Westchester Medical Center. And she wooed me. And I allowed myself to be wooed. And I have been here now at Woodland Pond for over 10 years. So not only is it the systems work that really drives me, I have the highest respect for healthcare workers, for my colleagues. The work that we do, that this panel of people do, that the CNA you pass in the hall does, that the housekeeper you pass in the hall does. The opportunity and the responsibility that we have in every single encounter to touch and hopefully improve someone else's state of existence, particularly when by the time they come to the health center, something went wrong, probably. It's an honor, it's a privilege, and it's a role that allows all of us to put our heads on our pillows at night and say, we did make a difference. We were able to make a difference in someone's lives. And some people towards the end of their lives wonder if they made a difference at all. And it is such a privilege to work in a field where we can say we did it 10 times today, and hopefully well, which is part of my role, what people come to me for. It's really my job to, yes, maintain all the voluminous regulatory requirements that we have, but also to make sure that we have a functioning, cohesive, communicative, supportive, and nurturing staff that can work well together, flourish together, toss about ideas together, make mistakes together, so that we may provide the very best medical and psychosocial care for the people who trust us. So I guess that's it in more than a nutshell.
If you pass your mic back. I'm going to start back again with Dr. Antoine. And if you could maybe tell us, what's a typical day? Just, I know there's no such thing, probably, I'm wrong to say that. What might be a typical day? And, a little interaction with whatever you would like to tell us about that.
For clarification, a typical day here or my typical
No, a typical day here.
Okay. Because that's a big difference. But okay. So a typical day here is I'm here 3 days a week. It's 3 days until I'm able to get everybody seen. So I would come in, do morning report with the team so that I can hear how things are going on all the units and provide my medical input or put people on the high risk watch list type of thing. I would then have my nursing staff go to the unit to pick up the query sheets that your nursing staff has placed on the unit saying that there's active issues ongoing. We then sit down and round as a medical team to say, okay, these are the labs, this is their profile, this is what we need to focus on with each individual that has some active issues. And then we would add in the individuals for a morning report that we need to ensure that we see or touch base or communicate with. For the individuals who we need to communicate with your family, we then do the family call as a team together so that everybody is hearing the same communication and no one is left out and we're all on the same page. At that time, my daughter is usually tracking the time and say, lady, you need to hurry up, you haven't gone to the floor, so she's on top of me. Then we do rounds with the unit nurse to be able to make sure that the nurse is seeing the visit, hearing the communication both from the residents concerned as well as what I need to be implemented.
She does everything.
And then usually I go back and have to sign off on all the consults that came in and review all of the active things that's pending to be done. So although I may want to be here only a certain amount of hours, that never works out, and my day is always very
And you're on call. You're always on call.
yes. Oh, I don't. I prefer to be on call. That way, when I walk in the building, I know what I'm walking into. So my phone is always on. Yes.
And I am correct that Gina is the director, is the unit nurse for skilled nursing, and I'm forgetting her name, that is the director.
Gia.
Gia.
Gia, I'm the unit manager.
Yeah, but you're the unit manager. But isn't there a unit manager also for?
Julia.
Julia.
Yes, so separate, she's
Julia is the
assisted
unit
living.
manager for,
AL.
AL and-
Yep, assisted living.
okay, just went like that.
Yes,
I
yeah,
might
so I'm
revise
just
it
for skilled
to see
nursing.
that.
Yes.
Yeah, she's not with us today.
Yep. So a typical day kind of differs depending on the day. My staff work 12-hour shifts, but I'm here Monday through Friday. I come in the morning, I meet with my staff, see what's going on the unit that day or anything that I might have missed. I attend morning report every day. We do morning report with the team, go over everybody, what's going on the unit, any issues and anything like that. And then I'll go back to the unit and meet with my staff again. We'll go over any admissions coming for that day, anything like that. And then every day is kind of different. On Wednesdays, I attend care plan meetings for most of the day. On Thursdays, I do weekly wound rounds with the team. I do it with the director of therapy and the dietitian. So we do wound rounds and see everybody on the unit that has wounds. And any concerns or issues that come up that day, I deal with that, every day. Notes, review care plans, kind of whatever's going on for that day that comes about, help the staff, assessments, things like that. So that's pretty much meetings, phone call, anything like that. Trying to think. Yeah, that's my day.
Sounds like a busy day.
Yeah, it's busy.
I would say for me, I'm kind of 24/7 as my position. So I usually start very early in the morning. I get up very early, like 3:34 in the morning. I usually contact with my night shift. Usually almost every night we end up texting each other at some point. I usually just find out what's going on in the building. When I get in, I usually just start my day, obviously check in my mailbox, my emails, get ready for a morning report that we have that starts at 9 o'clock in the morning. We do that Monday through Friday from 9 to about 10:30, depends on. We start off with assisted living morning report, which is the nurse comes down, the manager or their nurse if they're not here, and the whole team is there from fill-up, managers, therapy, dietitians, activities department, social work. And we just kind of go over the night before, anything that's going on, anything that might be going on during the day as well. So it usually ends around 10:30, like I said, depends on the day. After that, it depends on what's going on that day. Sometimes I'm working on policies, sometimes I would say every day I work on staffing. I'm very involved with the staffers, so I definitely oversee that. I check staffing every single day for the week, what's going on. I speak with my managers throughout the day. Any concerns they have, anything that might be something above them, they would come to me and I will handle that as well. So it's a little bit of mix of everything. Sometimes I go on the floors to meet with the nurses to do things. Sometimes I have a lot of visitors during the day that like to come and visit, so I usually set up some time for the nurses and the aides to speak with me. Sometimes families will give me a call and I'll meet with them as well. So it kind of varies throughout the day. We definitely do a lot of meetings and it just varies. That's it.
Okay, my day, I like to say it has a structured half and a less structured half. I also get to work generally pretty early, usually between 6:30 and 6:45, because I like to have the opportunity for the night shift to talk with me, or if I want to touch base with them. My morning then starts with, I do what I call chart review. I read every single progress note that's been written by every discipline in the past 24 hours. That helps me. I don't like to be what I call a suit and tie administrator, where I really have no understanding of what's going on the actual units that I'm being paid to oversee. I like to know what's going on. I'd like to know what's going on with each individual, if we have some systemic issues, or if there's a certain level of triaging that needs to be done of who may need more attention or less. I like to support my staff in full recognition of how busy they are. So if in that chart review I can catch something that we need to follow up on, something that may have fallen through the cracks, help connect the dots, I'm happy to do that. It's never a gotcha moment. It's to make sure that with so many moving pieces, so often that we can help tie things together. So I will read all the progress notes, make the notes that I need to in preparation for the reports that Deb talked about. I go over each and every incident report that's happened. An incident report involves generally anything untoward. It can be a fall with an injury, or it can be something as small as someone got a skin tear on their arm because there might be a rough edge to a wheelchair or something. But we go over all of those, make sure that we have a comprehensive root cause analysis behind why each occurred, and hopefully some substantial interventions of how we can prevent that. Then we do our morning reports, and then the second half of the day is really in response to the ever dynamic flow of healthcare. Things pop up all the time. I come to work fully expecting that there's going to be things that I never planned for, things I never thought of. And I tell everyone who comes into healthcare, that's what we do. We expect something went wrong, we expect something went awry, we expect a new difficulty or a challenge came up. It's part of the job. So the afternoon then is spent triaging that, helping staff come up with plans of how we're going to address certain issues, addressing certain issues that may come up within departments or with residents or family members that may have some concerns or challenges or even complaints. Not a dirty word. We expect it, and we try our best to find a way to meet expectations. So that's all part of it. Of course, on the administrative level, there's constant policies that need to be tweaked, constant regulations that are coming out. I have to stay in touch with our advocacy groups, as well as the state, who releases new expectations, new regulations and policies that we have to keep up with, make sure we're up to date on that. And of course, anytime Michelle calls me, I jump.
I was going to ask one more quick question, but the time, I don't know how long you want us to be here, Joe, wherever you are, but I think I'm gonna open it up to the floor and let you ask the questions, because I'm sure that you have many of them. So I think that would be time better spent that way. So let's get started. And if you would say if you're addressing your question to a particular person, say so, please. Say your name and your name.
I'm Bill, I'm in independent living. I expected to hear some interactions between Dr. Antoine and Gia or Donna. That's not Donna. Deborah. Or perhaps you can tell us a typical interaction that you've had, so we can get a sense of how it works as a system or as a team. Or is there nothing?
Interaction between us?
Yeah, between Dr. Antoine and
any of us could
any of you.
On a typical day, when Dr. Antoine comes in, she'll probably see me first and Philip, because she comes to our mailbox. So if there's anything that we need to talk about, then we will. I know for myself and Dr. Antoine, we could text, we call each other, we have open communication, we see each other. We also meet each other every morning after more report. Myself, Philip, and Dr. Antoine, and I think we're all going to be including our unit managers now as well. And we just kind of talk to start our week off, any concerns, any issues that we might be having, so that we're all on the same page. So that's something we do. I know me and Dr. Antoine even talk after hours, but that's kind of like I have Gia.
Yeah, that's fine. And I can pass it to her. So I communicate with Dr. Antoine as well as my nurses, via Tiger text. So any communication throughout, like we said, she's on call all the time. So, and they also text Debbie as well. So the Tiger text, and then when Dr. Antoine comes, as she said, she meets with the nurse, and she'll often see me, and we'll touch base if there's something that I have to Tiger text her separately about. Separate from the nurses, then I'll talk to her, that way, communicate, and then Deb and I talk every single day, yeah. So about anything, I just rope her into anything that I'm dealing with, and that's, yeah.
From a medical standpoint, I don't close my communication with anybody in the staff. I don't segregate anybody. If the cleaning crew says, hey, I think this person has an issue, or if I identify an issue that it's isolated, I will literally come and close the communication and give them a heads up. This is what I've identified, this is what I've heard, this is what has been said. So it's sort of a smooth flow type of communication that I don't know how to separate it from my day-to-day activity. So it's all in one, and they're part of. I don't see myself separate from the nursing team. We're all one team.
I'm Betsy Toole. I have a question for Dr. Antoine and one for Philip. No, yes. Dr. Antoine, do you meet with each person who comes into any of the units initially and go over their whole history and get to know them a bit?
So that depends on the unit, actually. The dynamics of this institution is such that if you come into skilled nursing, the answer is 100% yes. If you come into the assisted living facility, it is your choice if you want me to be your medical provider. And if you make that your choice and you want me to be your medical provider, then yes, you meet with me and my team, so not just me. You'll meet my nurse, because there's intervals of time where my nurse may need to check in on you or to come back and tell me what's going on. So she'll come with me on rounds so that we can all be part of the same communication thread. For the independent living, that is your choice again. If you choose for me to be your medical provider, then you would come and see me in the medical clinic on the first floor.
Thank you. Philip, I know there's once a week meeting with Michelle and a whole lot of other people where you review people who might need to come to the health center. Would you tell us the name of that and what you do?
So the name of that meeting is called PPS, which is an archaic name in that it was first called PPS because that was a designation of Medicare billing that was applicable 100 years ago. The name never changed. We now have changed the acronym, though, to mean Preventive Planning Services. So that was just so we didn't have to change a whole bunch of headings on paperwork from PPS. But the purpose of the meeting, yes, we have interdisciplinary staff from all aspects of Woodland Pond, independent living, assisted living, skilled, and we talk about you. We talk about how folks are doing. Are folks getting all the support they need? Is anyone in a state of crisis? Have there been any medical changes? All with the end goal of making sure that you're all receiving the support you need and the support you paid for. So if it does come up that there is some question about someone's ability to maintain retention standards of the various units, that is a place where that topic comes up. We talk about how we might be, our primary goal is always to keep people in their homes. To the extent that's possible and allowed by regulatory standards. If those gaps cannot be met by our efforts, then we do talk about what levels of care might be most appropriate, either on a short-term level or on a permanent level. Does that answer your question, Betsy?
Thank you.
I'm Larry Vandal, and I don't want it to be about me, but I do need to mention that my wife and I moved here to Woodland Pond in 2016, 10 years ago. And we lived for the first 6.5 years in independent living, very active and fit us both physically and in the life of the community. But in January of 23, I had a severe stroke, and after a few days in the hospital, that put me into skilled nursing for the Medicare one special 100 days, and then I was graduated, if you will, to assisted living, which is where I live now. So my point in saying all this is, and along the way my wife died suddenly, so I lost family support. My daughter also died. I lost family support there. Anyway, but I want to say I have seen, as Joni Mitchell said about something, I've seen it from both sides now. And I want to be very candid in saying I'm extremely impressed with the quality of the nursing care I've received here. With rare exceptions, they are superior and caring human beings. And I'm extremely grateful for that, and I can't think of a better place anywhere in this world where I could do better than I do here. Now, this is not to say it's perfect. It's never perfect. No such a thing. But anyway, I wonder if there are special, what shall I say, difficulties you find in being nursing administrators. For example, I know that in assisted living, there is one set of regulations from the state, and which also apply largely to Garden View, and there's a whole other set of regulations that apply to skilled nursing, and they aren't necessarily even remotely alike. So I wonder how, for example, how difficult it is to provide staffing, particularly when, due to the ever-present problem of finding sufficient staff, you have to move nursing and other staff members around from one part of the facility to another. And do you find it problematic in doing that? Does it present challenges?
Well, the regulations are definitely sometimes challenging because it's a lot to remember, a lot to know. We're not going to remember every little detail. Especially from a director of nursing standpoint, that I oversee all 3 units and the administrator, to know all the regulations and so forth. But with staffing, since I started here, I'll be going on 3 years here, I would say it was a lot more challenging when I first started. I think we've come a really long way with the staff and getting more staff in the building. And probably about a year ago, we started where everybody's getting cross-trained that can. There's certain people that can't get cross-trained. Like assisted living in GB, the HHAs can't work skilled. So there are some people that can't get cross-trained. So we're doing a lot of education, a lot of training. Sometimes it takes a little longer to get them trained. Depends on, it's vacation time, it's summertime, so more people are off right now for the training part. But I think overall the training's going really well. I think the more that we are doing cross-training, people are getting more comfortable with the units and learning the different things that they need to learn on each floor. So I feel like it's gotten a lot better since I started. When I first started here, nobody was floating or cross training. We implemented, like I said, I implemented that about a year and a half ago, and it's definitely has been slow going, but I feel like in the last year or so, it's been huge. And all our new employees in the last year, anybody that comes on board now, it's automatic training on all floors. So that way they just get comfortable right from the get-go. And I find that a lot of the staff, the newer staff, are enjoying that because sometimes you can get burnt out on a floor. Especially like a skilled unit maybe sometimes gets very busy. So sometimes they want that break and they're like, all right, I will take assisted living or GB. So I find that the newer people coming on, if we're training them right off the bat, it's a lot easier to start that. But there will always be challenges with that.
I just wanted to piggyback that to give Deb a boatload of credit for that. I've been here long enough that Deb is the third director of nursing since I have been here. And Deb has moved the needle on that cross-training of nursing staff more than any other of her predecessors. And she's done that with grace and firmness and fairness, and it's been very successful, I would say. So I'm deeply appreciative to her for that. I just want to comment real quickly, Larry, you were very astute on the differences in regulations. There are some vast differences in regulations between assisted living and garden view and skilled, and some of them are intuitive and some of them are insane. And as frustrating as it is sometimes when we have to enforce those, we're with you sometimes in saying, yeah, we don't love a particular rule necessarily. Just on a very practical sense, those of you who live up here on this unit and there's no more couches down on that end, it's because the state deemed that was dangerous. And so now what was a more home-like environment in the South Wing is not so much. That's only one minor example of that, but it's part of what we do when we took the job.
My name is Karen, and I've been here for just short of a year and a half. So in many ways, I consider myself an old-timer. In other ways, especially in relation to the health center, I'm a newbie. So I have a question for you, Dr. Antoine. Actually, it's a two-part question. The first part is, how, if at all, do you interact with independent living? And the second question is, you mentioned that you could, when you're brought into skilled nursing, you can either choose you to be your doctor, or I'm assuming keeping your current physician. So I'd like to know from you what that looks like and how it works.
Because I don't have my glasses on, so I can't really see that far back, so I apologize. So independent living, and because I'm new to Woodlawn, and it is very dynamic, and thank you for recognizing there's so many different rules. Gia makes sure that I'm always remembered of, hey, don't remember, you can't do this, we have to do this instead. So I do appreciate the lines that they draw for me in the sand. So from an independent living, it is similar to your primary care doctor's office. I would see you based on, you would call my office to say, hey, I would like an appointment. Even if you leave a message at the front desk to say, hey, I want to reach out if you're here locally, that's a different option. What we're trying to set up is so that for the individuals who want to have their family involved in their care and streamline that communication, we have a patient portal, so that patient portal can have any phone number be the primary person of communication. That way they have a direct communication to me and to my team, and you don't necessarily have to wait for a third party. So that process is still being set up, and because of the I'm a one-woman show type of thing. And there was a lot of people that I took on at one thing. So I'm trying to set up each section appropriately and to do it so that it's not haphazard and I'm not having people fall through the cracks kind of thing. So I've set up the skilled nursing. I'm in the process of doing the assisted living, And then come August and September, I will be focusing more on the independent and who wants to do that transition. And because I am by myself, I don't have a big regulatory bodies who can say, I don't like this, don't do this. So if you prefer something, that's easy for me to say, hey, yes, we can, or maybe we can come to a mutual agreement. Does that answer?
There was just one part of that I'd like to.
Yeah, there was just to clarify, on skilled nursing, it is only Dr. Antoine. People do not keep their private physicians, their community physicians on skilled nursing. The reason for that is we are required to credential anyone who works on our skilled nursing unit. So this is specific to skilled. It doesn't mean we're opposed to having other physicians, but most physicians are not willing to go through the process of leaving their community practice to become credentialed in a skilled nursing unit. So it is only, and I don't mean only as in it's just, we are thrilled to have Dr. Antoine as our sole provider and medical director on skilled nursing, but there are no other medical or physician options on skilled.
What does credential mean?
So credentialing means we do background checks, were there any kind of cases brought, is the education sufficient, is the insurance and licensing all appropriate, and we're required to go through that process to make sure that we're taking on quality candidates.
Thank you.
Glenn has a question.
Glenn Rothman. For the physician, have you taken any internship or residency in this country?
Oh yes, I did my residency in Wyckoff in Brooklyn, New York, in internal medicine. So I'm board certified in internal medicine. Sorry.
Great.
Are there, I might have to go to the dentist. Are there any other questions from anyone else on the floor? Where am I now?
I think it's Joe.
Did you want to go first?
We did a community connections with the activity staff and really appreciate how much the activities people do in the health center. It's really amazing. There's so many of them and there's so many good things. My other thing, this is for Dr. Antoine. When I've talked to residents about you, the first thing they say is, she's the first doctor I've gone to who really listens to me. So maybe you could talk about your philosophy of doctor-patient relationship.
I don't think I have a philosophy, but more of it's me talking to my mom, it's me talking to my aunt, it's me talking to someone who just needs me to hear you and see you, and I may understand some dynamics of the body and the mechanics of it, but I needed to bring it to your level, and I need you to understand or have you tell me what you understand. Medicine is not about me demanding that you do something, it's about you understanding how I can help you make your quality of life better. And that may be something of refusing care and what that means, or it may be me helping you through, okay, I don't want to do anything else, and what does that mean, and how can we then focus on care, because care doesn't only mean a pill, it means to talk to someone, to be heard, to understand that what you're feeling and what you're going through has meaning, and maybe there's something I can do to ease that comfort and ease that pain, and as long as I see I put a smile on your face, then I got my message across, and that can be in so many different ways.
Are there other questions? You have a chance. Okay.
My understanding is there is some interaction between staff at the health center and our nurse in independent living. So I'd like to know a little more about how you communicate.
Yes, there is absolutely some, the question was, is there some interaction between the nurse and the support staff or independent living residents and those in the health center? I forgot who had the question about that weekly meeting we have, but that's certainly, it was Betsy? That's certainly a primary source of that. Liz, Annika, Sarah Leonard, they all attend that meeting also. So that is an opportunity. We have, even in bringing on Annika and enhancing the support and wellness staff in independent living, that's helped us also be able to have those connections maintained if someone needs to come to the health center. So we get, for lack of a better word, a report on who this independent living person is if we don't know them from the health center perspective, what's important to them, what kind of level of supports that we have, so we can know them as an individual better should you have to come to the health center. And also they help to bridge that gap, to continue to provide a sense of a familiar person and a sense of support even while someone's here. And that's reciprocal. If it is the case that someone, and it's often the case, it's not just a one-way street, but if someone leaves the health center to go back to independent living, we can then reciprocate that. You know, here's the things we've been working on with this individual. Here's the things we're concerned about, or the areas that we'd like to continue to shore up support once someone goes back to independent living. So it is a very dynamic and reciprocal relationship.
Liz, can you pass that to Martha?
Hi, I'm Margot Elkin. Are you going to be addressing the new legislation in medical aid in dying?
Yes, we are. We already have, that is a meeting that is still yet to be held. I have been, part of when I said some of my daily duties is looking to see legislation that rolls out, how that looks, how that's interpreted by our advocacy groups. That legislation is continuing to be defined. The concept is certainly there. We will be implementing it. We're waiting to see what some of the finer points are from regulatory bodies of how that gets instituted, but it's certainly going to be a late summer, early fall meeting that will heavily involve Dr. Antoine and all our nursing staff, but we will absolutely be respecting and accommodating that. But the regulations on it are voluminous.
Anyone else? Okay, well, if not, I certainly want to thank all of you. Oh, I have one question.
Don't clap yet. It's Joe again. And this question is really for everybody, anybody who can answer. I had mentioned the activity staff and the mind-body connection. I forgot Tanya, also the nutrition connection is very important. Yeah, but my question is about your personal lives. It must take a toll on you. If you would like to, all talk about what your personal life's like when you're home. Do your loved ones resent the time, or are they supportive, or how do you deal with your other side of your life?
And hobbies.
Well, I'm holding the mic, so I'll start. That's a process, Joe. I think it's a process we could probably all relate in, and I don't think there's a finish line to that. Earlier in my career, I was, especially in a level of that kind of responsibility, was consumed, feeling responsible for everything, and that I had to control everything and prevent everything, and that nothing bad could ever happen. And you can imagine that doesn't lead to a super high quality of life. Over the years, just as Joe had mentioned, it's a process in setting healthy boundaries, setting expectations of oneself that I can't take away everyone's pain, I can't fix every problem. I need to put my head on my pillow at night knowing I gave it a really good shot. And the level of self-care that we do, that I pay attention to my own relationships, I pay attention to my own health. I have 2 adult daughters that the sun and the moon revolve around them. I have a husband who is incredibly supportive of the demands of my job, and what it entails, and I just try to make sure that sometimes I have to say no to things and not feel badly about it. And again, I think that's all a process that we undergo to say that we're not terrible people, that we can't do everything. I think expectation is the name of the game.
I would say I'm still working on healthy boundaries. I look up to Philip a lot because he's very good at that. So he reminds me all the time that I need to do that. I have definitely gotten better in the last year, maybe. I have a very supportive husband. I have a mixed family, so I have altogether 6 kids and 2 grandbabies. So I'm a very busy person at home as well. But I also find that lately I've been trying to slow down a little bit at times, and I just try to enjoy my family when I'm at home. But I have a very supportive family, so they know when I get the phone calls that I have to step away. It's part of the job, but I'm working on those boundaries. It's going to take me some time, I'm sure.
So I've had other jobs where I've brought a lot of work home with me, and kind of similar to what Deb and Philip have said as well, kind of trying to separate, and it's important to have the work-life balance. And here, I think with the level of staff that we have and then the support that I personally feel like I get, I am able to have that. I do have 2 young kids. I have a almost 8-year-old daughter and a 5-year-old son, a very supportive husband. So just try to maintain, take care of my health, myself, my family, and then, know that I've done everything that I can while I'm here at work.
I do not have balance. So I have a blended family of now six all girls. My husband is the only male. My nephew has now moved in, so now it's 7. One of my daughter's friends moved in. And we decided to get chickens so that I can focus on something other than caring for someone else. So and my chickens just had chicks. So I have about 30 chickens running around my yard. And with my mom's passing, she left me her cat, who does not like me. But he's the boss of the steps, so when you're passing the step, you have to pay toll of either begging for mercy so that you can pass, and all the animals look at me like, please help, we need to get by. So my house is always interesting. And I tell people all the time, please don't complain that I'm working. This is a vacation. Because when I stay home, it's always interesting. You never know what's going to happen. And in terms of, I compare myself to a couch potato because I said no one complains how long they've been watching TV. Why are you complaining how long I'm talking to someone? I'm enjoying this. This is great. I don't know how they could watch TV for so long. So that's truly my balance. And in order for my kids to understand and to, my husband is not in healthcare, so it took him some time to understand the dynamics of, hey, your shift ended, why didn't you come out? Because he does drive me and help me get from point A to point B without getting lost. So he has now understand that, the dynamics of I never walk a straight line in leaving a facility. I'm always pulled in some direction or another, and I get in the car and he's like, is it safe to leave now, or do we need to give it a minute because you might need to go back in? So he's extremely, extremely supportive from that standpoint. And out of the 6 children, 7. Oh my God. So my nephew is now considering doing the CNA program. All my girls have done the CNA program and worked in long-term care to understand what I'm dealing with. And prior to doing that, they did not understand what it meant when I said, I couldn't leave, or I'm sorry that I'm late, or I'm sorry I missed your event. And of recent, I've been told, Mom, I now understand why you say you can't leave, because it truly makes me feel happy that I gave someone a shower today, or I put a smile on their face and they were like, now I understand. So, yeah.
We just have a couple minutes, but I'll give it to Margaret.
Well, I was,
To close?
I'm just gonna say thank you, thank you, thank you. It was most interesting, and I loved your questions. Everybody had great questions. And I'm sure anytime that you want to contact them, we all know what their email is, because you know it's the first initial last name. So in any case, thank you again, and we look forward to seeing you.
Thank you for having us.
Okay.